concerns? Do I have a motion to approve?
So moved.
Second.
Okay, all in favor? We'll proceed.
Server, so we need the mics on. I know I'm gonna tell it, so.
My apologies.
Yeah, for the recording.
Okay, my apologies. So we'll go to the action items. The first action item is authorizing the submission of a resolution to the Board of Directors of New York City Health and Hospitals to authorize the Executive Director of MetroPlus Health Plan, Inc. to increase the contract authority for Accenture LLP in the amount of $3.1 million for a total not to exceed authority amount of $23.1 million for the remaining contract term. So I'll turn that over to Ganesh. Laura?
Afternoon. Oh, as the committee is aware, we're in the midst of a major core implementation of moving from PowerStep to a Health Edge system. It requires migrating from SS&C's legacy system to the new Health Edge platform. The implementation is known as Project Edge. It's a company-wide effort, anticipated completion date of December 2026. And it includes multiple go-live events throughout 2025 and 2026. Accenture is a management services consultant company that provides us with consulting support for the migration, including advisory support, implementation planning, requirements gathering, technical leadership, program management, change enablement, and regulatory support. Accenture was initially selected for this role in December of 2023 as the management services consultant for the Project Edge implementation. It was approved by both the Board of Directors for MetroPlus Health as well as Board of Directors for Health and Hospitals. Next slide. So as some of you are probably aware already, and I would be surprised if all of you aren't aware, the timeline has shifted for our Project Edge implementation. We originally had a April 2025 go live for wave one. After discovery with Health Edge, it was identified that there were a certain number of shortcomings with the application itself that needed to be enhanced and built. Therefore, it shifted our go live schedule. So from originally planned in April to October 2025. This shift for wave one has impacted all of the subsequent waves, and MetroPlus continues to need technical and functional resources from Accenture to ensure a successful completion of the Health Edge implementation. So we are seeking an increased contract authority of an additional $3.1 million for a total not to exceed amount of $23,100,000 to continue working with Accenture on Project Edge. We had a couple of change orders with Accenture that extended it into April of 2025. And then we had additional needs for continuing of the technical resources and functional leads who were supposed to drop off in June, and we want to keep them until 2026. The contract as originally written goes until March, so we're not looking for a contract extension, just additional budgetary amount to keep the resources on board. And so we're looking again to increase from the 20 million originally budgeted to 23.1 contract authority.
Questions? If they're
The same term, I'm sorry, I didn't check, does the term stay the same?
Yeah, the contract term remains the same. It's just additional resources that will continue on longer than originally.
because you had run out. In
Yes.
the original contract, so you don't need to extend the contract. You'll use that run out period, but you do need to pay for more time.
Yes.
More intense work during the period. If there are no other questions, I'll ask for a motion to approve.
Motion.
Second.
All in favor?
Yeah.
Aye.
Aye.
So approved. Going to the second resolution, authorizing the submission of a resolution to the Board of Directors of New York City Health and Hospitals to authorize the Executive Director of MetroPlus Health Plan to execute a 9-month contract extension and to increase the contract authority with Deloitte Consulting LLP in the amount of $3 million for a total not to exceed authority amount of $12.5 million. Yeah, Ganesh.
So in line with the shift in timing for our Health Edge project, so we are currently undergoing the same transition I mentioned. Deloitte has been a used in the capacity of testing, our testing efforts for all waves. As we're moving from information from the old platform to the new platform, they're doing all the validations. They, the board of directors had approved Deloitte as our testing partner originally on March 28th of 2024, and it was also approved by Health and Hospitals in April. We are seeking to do both a contract extension and an increased contract authority of $3 million for a total not to exceed $12,500,000 to continue working with Deloitte. Deloitte's original contract was from August 2024 to February 2026. We're proposing keeping the contract extension now until 2027 when all of our waves are finalized, and keeping the resources on until wave 3. So while we're extending the contract in the event we do need them later on, we're not asking for additional funding for resources. We're only asking for funding for resources until wave 3 is finished.
Bless you.
Next. Okay, that's covered. So Deloitte will continue to develop their test strategy, test scenarios, and the script design, the requirements traceability management, test data creation, execution, any defect identification, the management and reporting across all program phases of the testing. They're doing what's called in-sprint testing, system integration testing, so how two things connect together. And once they've tested those, then the end-to-end and parallel testing, meaning that claims will come into our old system. We'll run those same claims against the new system, make sure we're getting the same output. They're also responsible for testing all of the data that has been converted from the old legacy platform to the new one, and to look at performance in the new system as well, so that when we fully go live, we don't run into performance issues. They also provide support and execution oversight for user acceptance testing and performed by MetroPlus employees. So again, we're looking to increase both the contract and the spend. The spend request is for an additional $3 million to include also contingency for a new contract authority of $12,500,000. And the contract extension going all the way to March of 2027.
And you feel this will give you plenty of time as far as contract availability?
Yes, so wave 3 is expected in the third quarter. And then we have a BPaaS vendor that is going in our wave 4, but this is not inclusive of that, right? So the BPaaS vendor that we're going to go to, their responsibility is going to be part of the testing. But throughout the stability, we want to hedge against any issues. So we want the contract to go beyond into 2027 in the event we find any kind of anomalies during the stabilization period, and we need them to re-engage under our contract as well.
So it's the time contingency bill?
Yes.
Okay, great.
Is this the first time we requested an increase from the original contract authority?
Correct, for Deloitte, yes.
And for,
For Accenture as well. We had contingency built in, so we were dipping into our contingency,
okay,
and now we're
that's
starting
what
to
I-
exceed it, so.
Thank you.
Are there any more questions?
Sorry, just last thing, could you, separately, not now, just, note, what the original contract amount was, how much we've used of the contingency and how much we've added?
Sure, for all three?
Yeah.
Okay.
Thank you.
If there are no more questions, I'd ask for a motion to approve.
Second.
Okay, all in favor? Aye?
Aye.
Aye.
Okay. With that, we'll go to the third item, authorizing the submission of a resolution to the Board of Directors of New York City Health and Hospitals to authorize the Executive Director of MetroPlusHealth Plan, Inc., to execute a 9-month contract extension and to increase the contract authority with Source Edge Solutions LLC in the amount of $4,030,000 for a total not to exceed amount of $10 million.
Similar to the last two, I won't go through the background slide. We'll go to the next one. So Source Edge is responsible for our data conversion activity. So they're taking all of the data that is in the existing SS&C platform, migrating it, converting it and migrating it into our Health Edge platform so we can use that data. The original contract is from May 2024 to January 2026. Resources were supposed to start dropping off as of July of 2025 from the original plan. But we've identified throughout this process that there's a lot more complexity to the data. We are moving from a legacy platform that is over 30 years old. So there's a lot of complexity to the data. And so they've had to bring on additional resources. So there's a request from them for 12 additional resources that help to migrate this data. And so with this, we're asking for an additional, let's go to the next page. An additional 4,030,000, bringing our total spend to 10 million. Keeping on these resources that we currently have beyond the July, plus adding 12 more additional resources. The original amount of resources was 15 resources. We're adding 12 additional resources to that to help drive this all the way through, including to the point of stabilization. So in this, we're requesting both the contract extension as well as the resource extensions.
And the additional resources are in a similar allocation between levels as the initial 12?
And it's the largest percentage increase among the three contracts, and essentially doubling the original contract authority, and now you're adding.
And that's the key. They're going from having 15
I was
to
gonna say-
27.
Right, but when we originally entered into the contract, it's interesting that has the scope of work.
It has increased because as they started diving into the actual tables that contain data, there were a lot more tables than originally anticipated what we would have to migrate. And so as you were doing the discovery and understanding the information about our providers, about our members, about our claims, and how it's going to fit into the health edge ecosystem, it got really complicated because there's intermediary things that has to happen to take this data, because it doesn't just move the data from one place to the other exactly as it is, but they take it, they have to maneuver it, they have to reallocate it somewhere else in a way so that they're all talking to each other still, and then move it into the right places in Health Edge.
Again, we kind of had something very similar in the past. So familiar with, the implementations are more difficult than you imagine at first, because there are always some convoluted difficulties you didn't anticipate. So
Particularly when it's a really old legacy, like a mainframe system. And so as they started diving into it, there was a lot more complexity than originally anticipated.
Think this is going to be enough finish?
At this time, we do, because they've done most of the discovery. It's a matter of the actual work. So to your question, the only resource we didn't add was like program management. Is more technical in scope, so that they have the capacity to do it. So we do feel that this should be sufficient. I will alert the board that there is another ask that's going to be coming at some point. So with Source Edge as well. And what this is, so we've migrated 3 years of data from the platform that we have right now into Health Edge. Our regulatory obligation is 10 years of data. And so SS&C is essentially going out of business. And so they've offered for us to buy the product at $8 million so that we can have access, and that's a little bit too rich for our blood. Alternatively, what we're going to do is we have all the data, but we don't have an interface to see into the data for the remaining 7 years. And what we're going to engage Source Edge to do is to create an interface that'll talk to the data. And so individuals at MetroPlus, as needed, can log into this new platform, the new system we're going to build, to see the data at a more economical price point than what we would have to do with SS&C.
And what's the timing on that contract? Are we in negotiation?
We're in negotiation with them at the moment.
Is there any risk of SS&C like not being supported anymore before this is complete, or is the data pretty safe?
Our contract with SS&C goes until December 31st of 2026. And so while we were discussing with them to potentially continue to host it for us beyond that, there was a reluctance on their part to do that. And they offered for us to buy the code at $8 million. And we said, thank you, but no thank you.
Got it, but we still have 18 months on the contract.
Yes.
If there are no other questions, I'd ask for a motion to approve.
Second.
All in favor? Aye.
Aye.
Okay. With that, we'll go to the fourth resolution, authorizing the executive director of MetroPlusHealth Plan, Inc. to execute a contract with Wakely Consulting Group, LLC, an HMA company, to provide actuarial services for a term of 3 years with 2 one-year renewal options solely exercisable by MetroPlus for an amount not to exceed $11.6 million for the 5-year term. Lauren?
Good afternoon. So this is a cycle for a RFP on our actuarial consulting services. They include the calculation of our IBNR and claims liability, development of rate setting methodology. They review our medical expense documentation on premium rates, administrative costs, and assumptions for product offerings, and then ongoing professional consulting services. We released a request for proposal on March 24th, and Wakely Consulting Group was selected by the evaluation. The criteria that was leveraged as a minimum was the MWBE utilization plan. They must have experience as a supervising actuary, including consulting services, and they must have experience in the review and analysis of health benefit plan rate filing. We did evaluate the different firms that responded under the expertise in their analytics of unpaid claims liability, assuring that there was a efficient turnaround time to the plan to be able to close. The experience with New York State government and non-government products. In explaining trends and effects of UCL, the ability and availability of them to handle additional ad hoc requests, and expertise of staff to be assigned to the account, costs, and MWB. There were 4 vendors that responded, of which 4 met the minimum criteria. We did conclude our scoring on May 8th, and Wakely Consulting was selected by the evaluation committee. So the vendor evaluation, MetroPlus previously did contract with 2 actuary firms and is electing to proceed with 1 vendor for this contracting cycle. We do manage the transfer of all data, such as the UCL, and this between 2 vendors was creating inefficiencies and required additional administrative support. So consolidating will streamline communications and eliminate duplicate work. Additionally, we project savings of approximately 6% annually by contracting with 1 vendor. And Wakely is one of MetroPlus's current contracted actuaries, and we have had a very positive experience with them throughout the years. They have displayed the best technical capabilities and expertise, specifically with their ability to pivot along MetroPlus's transition to a new claims processing system. So we are seeking a 3-year option with 2 one-year options to renew. The anticipated contract date of September 1st, with the total authority request of $11.6 million. That does include contingency. Wakely submitted a 10% MWBE utilization plan and is requesting a waiver for the remaining 20%. The selection of Lupton Actuarial and Consulting, a certified MWBE, has been their partner as well in the existing contract period.
So Lauren, do the 2 renewals have to come to the board, or are they just done based on management's decision?
They were no, the two actuarial firms that are in place now.
No, my apologies. You have a 3-year contract with
Yes.
2 renewals.
Yes.
Each of the renewals, do they have to come to the board?
No, they just did management discretion.
Lauren, you,
Board would essentially be approving them.
Yes, I just wanted to make sure that was understood.
you've made extraordinary demands of Wakely over the years.
Yes.
Yeah, you want to take a minute to talk about how quickly they respond? Oh, how quickly they respond, and just go above and beyond.
They are an extraordinary partner with us, and depending on where our investments and discussions are occurring, being able to produce modeling that is actuarial sound that we can inform our forecast by is critical. And they have just been a outstanding partner all through our relationship with them. They also are a leading actuarial firm in our industry, in our region, and our coalitions look upon them to do, different rate exercises with the Department of Health to assure that the rates remain, adequate and standard. I think that, they have a depth of knowledge that crosses all of our lines of business and are able to reach in depending where we need to, pull some expertise. So they have just been an outstanding partner all of these years that we've worked with them.
Terrific. I'm glad that we're turning to them now.
Well, and as far as I can remember, their forecasts were on target or we performed better. I don't think that they ever worked with us on the forecast that, ultimately turned out to be more
Right.
positive than expected. So
Mhm.
that gives, I think, us and should give the board comfort level. Yeah.
Absolutely. Okay.
If there are no additional questions, I make a motion to approve.
Second,
So moved.
Okay, all in favor? Aye. All right. With that, I'll turn it over to Lauren to discuss new business, the Finance Committee report, the first quarter.
Well, good afternoon again. So a couple of items that have been realized through Q1, including rate updates on a number of our product lines. So we did receive the April 2024 version 2 revision for Medicaid, a small increase of about 0.2%, valued at about 3.7 million across 12 months. The drivers behind here include base rate updates that were then offset through across the board decreases and the fiscal intermediary administrative carve out effective August 24. On the HARP line, totaling a negative 5.2 million impact over 12 months or 1.5%. We did see increase on base rate updates, but again, through the ATB decrease and pharmacy carve out effective 2024, that yielded a negative change. Our 2025 Q1 MCOR P&L finalized on in the last few weeks had a medical loss ratio of overall of 92.6% across our 11 lines of business, running a lean administrative loss ratio to forecast at 7.6% and still maintaining our overall 2% margin. Incorporated in our P&L through Q1 is the managed care MCO tax that went into effect Q1. We also saw performance in our QHP and Medicare lines of business. So they are both showing stable performance from historical. And as we are moving through 2025, we are continuing to see trend on the Medicaid and HARP lines of business that are leading to deterioration in the ultimate performance of that line of business. On our administrative expense budget, we did end the quarter favorable, 4.2 million or 4.2% favorable to budget, of which the breakdown between personnel and non-personnel expenditures is 2.8 million versus 1.4%. As we were just talking about the forecast for MetroPlus in 2025, revenue net of pass-throughs was about 1.4% higher than anticipated, and overall expenses are about 2% also higher than anticipated. We are seeing some uptick in the essential plan EP5 tier that was driving higher than anticipated expenditures. And we have realized a current year margin of 1%, inclusive of any prior period adjustments that did push our overall margin up to 2%. So if you look at our net income year over year, we have had significantly better performance overall. That is a Q1 2024 $13 million net income versus the 26 million 2025 number on the there are some rates updates that are coming down the pipeline from DOH. So excluding our MCO tax, the Medicaid and HARP line of business will be receiving an increase of 9% and 1%. We are seeing a significant increase in the base rate data from 22 to 23. And so they have also made adjustments for increased utilization after COVID and updated CRG scores. On our risk score.
Wait, Lauren, but that's just enough to essentially break even, right?
So that's
This number seems
it,
astronomically high
Yeah,
compared to
yes.
historical, but
yes. So this number is the highest we have seen as far as I can think back. Medicaid is a deteriorating line of business, and even with this 9%, the line of business is unlikely to show a positive through the remainder of this year and is forecasted as such. And then understanding how some of these changes that will be forthcoming will determine if the 9% will have any retroactivity to further reduce it. So that remains to be determined. But no, it is not a picture of the 9% increase going to make a.
we're still underfunded, right?
We have been funded at the bottom of the range in the Medicaid line of business for at least the last 5 to 7 years. And so that is an increase of 9%. We're still at the lower ranks as they use our experience to create the rates year over year. One thing to know is the after COVID utilization, the leavers versus the stayers. We are, right, the experience of the population, the folks that are remaining on the Medicaid are higher utilizers with higher acuity needs. And so their trend on their medical expense, we have not seen, we don't believe we've seen the peak yet. It's still quarter over quarter, climbing, yeah. But on our risk score side, we are seeing increases in our TANF child and TANF adult population, while we did see slight decreases in SSI and HARP. It is worth noting that for the HARP line of business, MetroPlus does serve the most acute population within our region. And then on the HIV SNP program, partnership and care, essentially this is a flat budget change year over year of about 0.5%. There, even though the base rate increased, there was a offset in care management and the admin component post the RX carve out net is about 55,000 across 12 months. There are other changes that are coming down that will both revise April 2024 rates again and then impact 2025 and the out years. So we are seeing for the 2024 rates, we will pick up the MCO tax effective January. The state is going to revisit the FI carve out that was effective in August 2024. And there are continued conversations around the population acuity associated with the end of the public health emergency. In April of 2025, we have now moved to a single statewide fiscal intermediary. There are a number of enacted budget proposals that will start to move through the plans, and a transition of doula services will be coming into the managed care program. In mid-year of 25, we will see updates to both the Child Health Plus and Essential Plan that will revisit the MCO tax. And so for our assets, we have a total of $2.8 billion in assets, which has increased at 11.3%. There are a number of components here where we have the outpatient upper payment limit for state fiscal year 2024. There is the accrual of the MCO tax as we anticipate the payment from New York State. We also are increasing about 24 million related to the NIRE social care network entities, and then also a 42 million anticipated earn back for encounter data to the plan. On the flip side, for liabilities, you can go next slide. We have liabilities of about $1.9 billion. Again, that includes the outpatient UPL, a number of audits that the plan is working through, and then our value-based payments expense arrangements. In total, our net worth about 944 million, which has increased about 2.2%. I'll just note one other thing on that slide, that our contingent reserve at 63.4% is valued against our overall. In investments, we have a strategy where,
Sorry, Lauren, can you remind us the MCO tax impacts the reserves or doesn't?
it does impact.
It does.
As of now, it does.
Okay.
For investments, we have a total of $1.4 billion invested into treasuries, and our yield to maturity at about 4.2%. Interest rates are coming down as we see that across the region. Our current yield to maturity lives at 4.2% overall. Membership is stable. It has been stable throughout since about October of 2024. And so currently, when we closed Q1, we are at just about 690,000 lives, and through June, that number is still staying consistent. Market share also remaining consistent. The dark green bar on the right side is our most current performance. So for our largest lines of business, like the managed Medicaid, slightly had a 0.1% uptick since December of 2022, and we are seeing our Child Health Plus growth continue to be maintained as each month goes by. And then on the federal risk, you want to take that one, Raven?
Good afternoon, everyone. Just wanted to give the committee some knowledge about what's happening at the federal level and the impacts on New York. Obviously, this is all an assessment of what we know from the bill that passed the House. The Senate has reconvened this week, so we are expecting to see some changes to this, but we're currently always working from the information that is available to us at the time. So these are just some critical components of what we are expecting to see at least some version of as the federal budget goes forward. First is restriction of immigrant coverage. This is something that you're going to see across the board, a reduction of the populations that are considered lawfully in the U.S., eligible for government programs and coverage. And one of the critical components is that any state that provides coverage to individuals who are not considered in the lawfully or legally present category will, even using their own dollars, will receive a 10% penalty on the federal dollars that they receive for those populations. New York State does have a New York court decision, the Aliesa decision, that indicates that New York has a New York State constitutional requirement to cover those populations. And so as of now, this would be a major impact for New York. The reduction of and restriction on who is eligible for premium tax credits and Medicare eligibility. Again, this is about the eligible alien population shrinking. This is most impactful for New York's essential plan, as premium tax credits are what is used to fund the program, as opposed to in the QHP, where the premium tax credits go directly to the recipient to reduce their out-of-pocket costs. EP as a whole is funded through the premium tax credit dollars. On the Medicaid side, there is a conversation about implementing mandatory work requirements as a condition of eligibility. The timing of this is very much up in the air, but it could begin as early as 2026. And then would be a number of additional layers of red tape that they are proposing to add to Medicaid eligibility, including moving from eligibility checks once a year to every 6 months, reducing the retroactive Medicaid eligibility from 3 months to 1 month. So for everyone's recollection, if you apply for Medicaid today and you are able to produce expenses and other things going back 3 months, Medicaid would normally retroactively cover you for those 90 days. Now it would only be 30. There would be potentially, some states are considering options for cost sharing if your income is above 100% of the FPL. And then, as you heard Lauren mention multiple times, the MCO tax, which is being used by the New York State legislature and other agencies to fund quite a bit of the New York State budget. It is expected that the administration will remove the ability of that tax to exist, and that would go retroactive back to when it started in 2025, based on what we are currently hearing. And so those are all risks that we're keeping our eye on, and obviously we'll keep the committee up to date on those that get more solidified and new risks that appear on the horizon as the Senate goes through their process. Are there any questions about this?
And the MCO tax is gonna be gone this year.
Yes, it would go,
25.
it would go back to retroactively when it started, would have been 1/1/25, correct? Yes.
I just had a couple of questions on other slides and one question for Lou. The doula services are across different lines of businesses or just Medicaid?
Just
Just
Medicaid.
Medicaid.
It's a place already, right?
Yes, doulas went live on April 1st.
Oh, okay. Yeah, I guess I read today somewhere where they want to make it much, much broader. I don't know where that.
So there's a lot of proposals that were not a part of the New York State budget, but are proposals that are in front of the legislature, and a significant number of them are related to service coverage and expansion. So I'm not sure precisely what you read, but you might have read about some of those proposals. I think there were definitely in more than 20 proposals about mandatory coverage, things of that nature. So we're also keeping an eye on what the New York State legislature is doing in this last little bit of time before it closes out for session.
Yeah. And on personnel savings, are the savings through attrition or selected or a combination?
So on the PS side, it is just for folks that we had new needs that haven't been hired, or from staff that have departed. That is where that savings is being generated. And then on the OTPS side, we had a number of vendors that we anticipated expense at this point and has not materialized.
Okay, thank you.
Oh, do you want to take it? Okay. So this is what did pass officially in the New York State budget this year. So it included full elimination of quality funding for the managed long-term care and MAP programs. It also gave additional authority to the state to level penalties against managed care organizations, and the violation range now can go from $25 to $25,000. And obviously the MCO tax passed. New York State has been proceeding with that, as we talked about, although that is likely to go away. Another impactful component for us is that they are seeking to carve coverage of nursing home services back out of managed care. For those who've been in managed care a long time, this will be the third or fourth time it's gone in and out of the managed care package. And now it will be going out again. Currently, the proposal is for the end of this year. We'll be obviously monitoring the timing of that.
We have the number of members that are impacted.
Not in front of us right now, but we can get it. Yeah.
It was not meaningful, is it? Or is it ballpark?
I wouldn't even want to ballpark it. I think meaningful in terms of membership, small, meaningful in terms of expenditure, significant. Yeah. And also capitation, right? Because they move into a different tier. And then
300.
yeah. And then unfortunately, they did not include the provision to remove Medicaid from the independent dispute resolution process. The main concern here is obviously that Medicaid functions on a Medicaid fee schedule and according to government program dollars, but the IDR process is entirely based on commercial frameworks. And so they use the commercial database of provider billed charges to determine what is reasonable payment in these cases. So it drives up expenditure in the Medicaid program significantly, but it did not make it into the budget. And that's that.
Jeffrey, you want to take us to the KPI? Oh,
Just
sorry.
a quick question. The 10% penalty for undocumented, was it? What does that translate into?
It's an FMAP reduction. So the amount of money that New York is
I believe it was 2.7 billion, but I would have to double check.
state, that would be the total impact for New York.
For all of New York.
We don't, yeah, we don't.
Our
We
number's not-
can't change that into Metro Plus dollars because it's entirely how the state is funded. It will go into rates, it will go into, it's just a single component, but it's about what the state can fund, but we don't have Metro Plus dollars associated to that.
Okay.
Directly.
Exactly.
The KPI?
Yeah, sure. So we started a new series this year where we went company-wide and tracked down all of the key performance indicators for each department throughout the whole organization. You can see there we've got about 260 total. Here's the different departments that we've covered. And for each KPI, our goal really is to start to track the current value, either month over month or whatever the typical measurement period is for that particular KPI. Compare that against current goals we've established. So month over month or period over period, how are we doing against our goal? And look at those variances. Additionally, looking at prior measurements. So how are we trending month over month or quarter over quarter? And also establish benchmarks for each of these KPIs. So for each KPI, we want to know how are we performing? What does it mean? How are we compared? How are we trending? And where possible, how does it compare to some type of a national benchmark, or in our case, we're also working with Wakely, for example, to establish some of those key benchmarks for each KPI. So we review these monthly, and in some cases we do them every other week. And it's really helping us really enterprise-wide across the organization to understand how we're performing in all the different areas, and how, enables us to take action and change direction as needed.
Any other questions?
It's a significant new initiative, isn't it?
If there's no other new business, old business, I'll make a motion to adjourn.
Moved.
On favor?
Thank you.